I'm Dr. Asim Javed and I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning of image interpretation in coronary intravascular ultrasound.
A quick reminder of the anatomy. That's the adventitial layer. Then in between is this black line, which is the layer of media. That's the smooth muscle. And then inside the smooth muscle, you can see there is this plaque. That's the intimal layer which contains this plaque. This is eccentric plaque because it's more on one side as compared to the other side. And then if you line with this red marker, it's lining the intima from the inside. And what you have in the red line, this area is the lumen. That's the lumen which is inside the intimal layer. And this lumen area is used to assess the lesion significance. And it is measured in millimeter square. This is area. Now, these green lines are the diameters. That's the smaller diameter. That's the larger diameter. This is measured in millimeter. And this is the one that is used for calculating the size of the devices to be used, like the balloon or the stent. What is plaque burden? This is defined as ratio of atheroma area to vessel external elastic lamina. So what it means is, that's the lumen that's been shown here in the white. That means this is the intimal border. This is the intima. Then you have this intima contains this whole plaque which is in gray, and then outside the black line is the media. And we know that the media has an inner lining that's called the internal elastic lamina, and an outer black lining that's called the external elastic lamina. And outside this external elastic lamina, this is the adventitia out here. Now, to calculate plaque burden, what you need to do is first calculate the plaque area. So how do you calculate that? You can calculate this lumen area by putting a red line here on this intimal border, and you've got this external elastic lamina area. If you subtract this lumen area from this external elastic lamina area, what you are left with is the plaque area. So this is what's written here. Plaque area is equal to external elastic lamina area minus the lumen area, and the plaque burden is equal to this plaque area divided by the external elastic lamina area. Actually, this plaque burden is the plaque plus media, and in the prospect trial, in the non-culprit vessels, this plaque burden, if it was more than 70%, it was associated with long-term MACE. Now, where do we do the measurements? Ideally, if that's the lesion, we should go at least 5 millimeters proximal and 5 millimeters distal, and take these as the reference points for doing the measurements, provided these are normal areas. Or there is a further definition to the distal reference and proximal segment, which we will discuss now. How do you decide where to land the stent, especially if it's a diffuse disease? Remember that if you want to measure the lesion length, it is measured with automated pullback. By pulling the IVUS catheter with your hand, that's a manual pullback. You cannot have a calibrated speed, a uniform speed of pullback. Therefore, the length cannot be measured. If you want to measure the length, it has to be a device pullback and automated pullback. So now you've got a proximal reference segment and you've got a distal reference segment, and in between with the automated pullback, the length can be measured. Now, the optimal landing zone distally and proximally are the areas which have less than 50% stenosis. In other words, these landing zones should ideally have less than 50% plaque burden. So the stent must not start or end in a soft plaque with lipid pool, because the lipid pool is the one which is necrotic area, and that needs to be stented. You cannot end your stent or start your stent in an area which has more than 50% plaque burden, and especially if it has lipid rich core, you just need to cover that area. You can't leave it at the stent edge. So how do you optimally size your stent? So at the distal reference segment, you go from intima to intima. That's the lumen. So you measure the lumen diameter, and that's the diameter of the stent that you will select. At the proximal level, again you will go intima to intima, and what you want to see is good optimization of your stent. It should be well opposed, there should be no stent edge dissection. That is what you are looking at the proximal reference segment. Now, at the site of the lesion, that is shown here from media external elastic lamina to external elastic lamina. Now, so this is where you want to calculate the post-dilatation balloon size, your NC balloon size. So what's recommended here is that you will, whatever you get as a size from external elastic lamina to external elastic lamina, that's media to media, you downsize that by 0.5 millimeter, and that's the NC size balloon that you want to use for post dilatation. So the size would be somewhere between the lumen and the external elastic lamina. So intima and external elastic lamina, in between there, that's the size of the non-compliant balloon that you want to use. And then of course you can calculate the distance of the lesion, that's the landing zone or the length of the stent, but that is provided you use automated pullback system, because that's the only way to find the exact length of the lesion. Now again, this is very important here, that if you are using at the distal reference segment lumen to lumen, that is intima to intima, to calculate the stent size, then you can upsize the stent by 0.25 millimeter or go 1-to-1 with the lumen size. Or if you are using external elastic lamina based sizing, that is from here at the distal reference segment, you are calculating the size from external elastic lamina to external elastic lamina, then you should downsize the stent by 0.25 millimeter in order to remain in a safe range.
Now, this is a very important slide. IVUS criteria for optimal PCI, and this is mainly based on the ultimate trial, which showed that if you meet these above criteria, then the target vessel failure at 12 months was much lower than if you could not meet these criteria. It was 1.6%, 4 versus 4.4% if you could not meet. So what is it? One is based on the minimal stent area. So after deployment of the stent, you have to calculate the area that you've gained from the stent, and that has to be more than 5 millimeter square for non-left main stem lesions, or more than 8 millimeter square for left main stem lesions. The other point is that it could also be more than 90% of the distal reference segment. So whatever distal reference segment you have, from that area, this has to be at least more than 90%. Then it's a well expanded stent. Again, just to repeat the point, that for non-left main stem lesions, it has to be more than 5 millimeter square. This is the inside of the stent area, and more than 8 millimeter square minimum stent area if it is in the left main stem. The other point is the plaque burden. We just discussed that wherever you are landing the stent, the proximal or the distal stent edge, there should be two things that you need to look at. From 5 millimeter proximal or distal to the stent edge, the plaque burden should be less than 50%. So it should be less than 50% stenosis there, and it should not be lipid rich core. The lipid-rich cores or more than 50% plaque burdens need to be covered in the stent. You can't leave your stent edge close to that. The third point is about dissections. The dissection should be limited to the intima if there is any stent edge dissection. If it covers the media, it's a deep dissection, and it is more than 60 degrees arc, or it is more than equal to 3 millimeters in length from the stent edge, then it needs an additional stent if this happens. And then as far as the malapposition is concerned, that's the fourth point, that if there is a gross malapposition with a length of more than 3 millimeter, it should be corrected with post-dilatation using appropriate size non-compliant balloons. Now, these are very important 4 points. I'm going to show you the same points on this diagram again, that if there is a distal reference segment, here what you need to see that the plaque burden needs to be less than 50%, and there should be no deep stent edge dissection involving the media.
The same thing applies to the distal reference segment, plaque burden less than 50%, no edge dissection, and then within the stent, you have to see the minimal stent area. There has to be an adequate stent expansion, which means the minimal stent area has to be more than 5 mm square for non-left main stem, or more than 8 mm square for the left main stem, or more than 90% of the distal reference segment. If that happens, it's a well expanded. Now, this is a very important slide. Now, this is EAPCI consensus for post PCI optimization targets. In other words, this is the IVUS criteria for optimal stent implantation. So, what is the criteria? So, if you look here, the stent where it starts and where it ends, the plaque burden should be less than 50% at the stent edge, and there should be no lipid pool. Then there should be no extension of or protrusion of any plaque or material inside the stent. There should be no significant malapposition, and what we mean by that is that the acceptable malapposition is less than 0.4 millimeter distance from between the stent and the intima, and it should be less than 1 millimeter in length. So remember that in malapposition, it means the stent is not touching the intima. If it is touching the intima, in contact with the intima, then it is a well-opposed stent. Then the other thing is dissection. So the dissection should be less than 60 degrees. The flap should be limited to the intima only, so no medial extension, and the flap should be less than 2 millimeter in length. Then what about the minimal stent area? So for the non-left main stem lesions, the minimum stent area should be more than 5.5 millimeter squares on the IVUS. And then you can also see the expansion of the stent. So how well expanded the stent is. So you can either use the minimum stent area over the average reference lumen, which should be more than 80%. Average reference lumen means you take out the MLA of the proximal or distal segment, and then the proximal segment MLA, and you compare it with the minimal stent area here, and then you say it should be more than 80%, then it is well expanded stent. So if we want to look more into the expansion thing, so the other way to look at is to do the comparison with the distal lumen reference area rather than the average of proximal and distal lumen areas. So here if you see the stent, the minimal stent area is 6.8 millimeter square, and how you take it out is by putting this blue line inside along the stent struts. So this round circle there in the light blue, this is showing the minimal stent area. This is 6.8 millimeter square, and the reference MLA, which is lumen to lumen, intima to intima, you put this blue circle here, and this MLA is 7.5 millimeter square. So 7.5 millimeter square at the distal reference segment, 6.8 millimeter square is the minimal stent area. So this comes to almost 91% expansion. So this is well expanded stent. Now another example you can see here, angiographically it looks under expanded, but now if you see the MSA is 5.3 millimeter square and the distal reference segment MLA is 7.8 millimeter square, this comes to 68% stent expansion. So this needs more post dilatation. Reinforcing the same concepts, we can see here that's adventitia, the black line is all media, inside media is the intima, and in the intima there is all this plaque that is sitting there. That's mainly eccentric plaque because it's mainly concentrated on one side as compared to the other side. And then if we mark this intimal border on the inside, which is now marked here as blue, that is the lumen area. And if we mark this black line on the outer side, that's the external elastic membrane area. Inside the lumen, this is the IVUS catheter that is sitting there, and this white shadow is that of the guide wire. And this plaque plus media area is actually the atheroma cross-sectional area. Now, at the proximal reference segment, you calculate the same things. That's the lumen area and the external elastic membrane cross-sectional area. You calculate the same at the lesion site, you calculate the same at the distal reference segment site. Then what else you can do? You can calculate the minimum and the maximum lumen diameters at the site of the lesion, at the proximal segment reference, at the distal reference segment. Then at the same time you can also measure the plaque thickness. You measure it, the minimum, that's the minimum, and the maximum plaque plus media thickness from the media to the inner intimal border. Wherever it's the maximum, that's called the maximum plaque plus media thickness, and at the site of the minimum plaque media thickness. For research purposes, you can calculate all of these things here. At the distal, at the proximal and the distal reference segment, you can calculate the external elastic membrane cross-sectional area, that is marked here in yellow. That's 20.4. You can even take out the average reference external elastic membrane cross-sectional area. How do you take the average of the name is indicating what it means. Average reference external elastic membrane cross-sectional area. So average reference means the proximal and the distal reference. You calculate the average of both of these cross-sectional areas at the external elastic membrane level. So at the proximal segment it is 20.4, at the distal segment it is 13.3, these yellow lines. So if you want to take out an average, that means 20.4 plus 13.3. For average, you divide it by 2, it comes out to be 16.9. We'll talk about the importance later on. Now, okay, we can talk about it now. If you want to calculate whether it's positively remodeled or negatively remodeled, what does that mean? That at the proximal reference segment, we know that the arteries proximally are bigger size, and as you go distally, the size becomes smaller, right? So at the proximal reference segment, if the cross-sectional area is 20.4 external elastic membrane, at the distal reference it has to be smaller, which is 13.3. It's smaller, so this is okay. But at the lesion site, this one is 21.6, which means this is even bigger than the proximal reference segment. If it is bigger than the proximal reference segment, you can see that the artery has grown bigger at the site of the lesion. That means this is positively remodeled. But if you want to take out this in the scientific formula way, then you calculate the average reference segment by adding proximal and distal reference segments and dividing them by 2. This average comes to 16.9. Now at the site of the lesion, this external elastic membrane cross-sectional area is 21.6. If you divide this 21.6 by 16.9, it comes to 1.3, and this is called positive remodeling. We'll talk about it later. Now you also can calculate the lumen cross-sectional areas, the plaque plus media cross-sectional areas, maximum lumen diameter, minimum lumen diameter, eccentricity indexes, plaque burden, the arc of calcium, how much the calcium arc is. You calculate all of this. Now again, to show you the concept of remodeling, you can see positive remodeling, that at the site of the lesion it is even bigger than the proximal reference segment. What is negative remodeling? That at the site of the lesion it is even smaller than the distal reference segment. This is positive and negative remodeling. But if you want to put it in the formula that I just explained, that at the site of the lesion you calculate the cross-sectional area of the external elastic membrane, and you divide it by the average reference external elastic membrane cross-sectional area. If that is more than 1.05, that is positive remodeling. Like in previous case, it was 1.3 in the last slide that I explained. That was positive remodeling. And if it is less than 0.95, this is negative remodeling. Just to strengthen the concept further, this is an example where the cross-sectional area of the external elastic membrane is 8.2 millimeters square, and at the distal reference segment it is 7.8 millimeters square, and at the lesion side it is 6.4 millimeters square. So you can, from the eyeballing, you can see that at the site of the lesion it is smaller than the distal reference segment. This has to be negative remodeling. But if you calculate by formula, then the average of these two reference segments comes to 8.2 plus 7.8 divided by 2 is equal to 8, and then the remodeling index comes to, at the site of lesion, 6.4 divided by this average 8 comes to 0.8. That is less than 0.95, so this is negative remodeling.
On the other hand, you can see here the external elastic membrane area is 20 millimeter square, whereas this at the site of the lesion is 21.3 and at the site of the distal reference segment is 12.6. So this one is bigger at the site of lesion. It is bigger, even bigger than the proximal reference segment. So this is positive remodeling on eyeballing. But putting everything into the formula, the average comes to 20 plus 12.6 divided by 2 is equal to 16.3. So at the site of lesion is 21.3. So 21.3 divided by 16.3 is 1.3, and anything more than 1.05 is positive remodeling. So this is the case of positive remodeling. How do you calculate the final minimal stent cross-sectional area? So you just mark the inner surface of the stent and you draw this area here, and this is the final minimal stent cross-sectional area. So this is a 55-year-old gentleman, had PCI to RC in 2018. Circumflex was totally occluded at that time. Now he's presented with angina CCS class through despite of optimal medical treatment. This is his current angiogram. RC is patent. Circ is occluded the way it was in the past. But if you look at the spider view, you can see there is no contrast flashback coming from the left main ostium. So there is possible left mainstem ostium disease or spasm. So nitrates were given. These are further views. There is some form of diffuse moderate disease in the LAD that you can see here. Again, there is some moderate disease in the proximal course of the LAD segment here. And then looking at more views, again you can see there is some disease in LAD, even just as the diagonal takes off after this one, the second diagonal as it takes off, there is some disease here in this segment of the LAD as well. So this IVUS run was done in the LAD, and what it shows is diffuse mid to proximal LAD disease, and the minimum lumen area at the tightest point in the mid LAD was 3.1 millimeter square. And then at the left main ostium where we had the doubt, this is the IVUS catheter going in and coming out. At the ostium we wanted to be very sure, and here the minimum minimum lumen area was 5.9 millimeter square. So this was at the tightest spot. So we do know that less than 6 millimeter square you can go for revascularization. More than 7.5 it says here, that's no revascularization, and between 6 to 7.5 it's additional input that's required, which could be an FFR. The cutoff that we use now is less than 6 and more than 6. So by and large, this goes towards revascularization if it's less than 6 millimeter square. But we went on to do an FFR. We wanted to be very sure. Since it's a question of doing FFR in the left main ostium, therefore the guide catheter has been disengaged to normalize the wire. So normalization is done with the guide catheter disengaged, and then the wire was placed in the distal LAD. So it was the accumulated FFR of the whole LAD and left main stem that we were looking at, and the reading was done with the guide catheter disengaged. So the FFR came out to be 0.67, and when you enlarge the waveforms you can see that there is no drift here. This is a proper good tracing that we have. But you also see that there is a diffuse disease in the LAD segment, and this step up that you see here is right at the ostium of the left main stem. So that's where the more significant part is. So this patient has a diffuse ostial LAD, ostial left main stem to mid LAD segment disease and obstructed OM. So this patient opted for CABG